Section 8 is on pediatric and adult trauma. Here we have dealt with commonly used classifications in trauma. First part is pediatric trauma. In 1963, Salter Harris described 5 types of physeal injuries, fifth one being a compression injury of the physis. In 1969, Salter Harris type 6 was added by Mercer Rang. In 1981, Ogden proposed a classification which consisted of 9 types and 11 subtypes, making altogether 20 types. Most commonly and widely accepted classification is still that of 1963 Salter Harris classification for physeal injuries. Montagia fracture dislocations classified by Bado classification type 1 to type 4 and have 2 components to each type. Type 1, A. Anterior dislocation of radius, and B. Anterior angulation or fracture of proximal or middle third of ulna. Type 2, A. Posterior dislocation of the radius, and B. Posterior angulation or fracture of the proximal or mid third of ulna. Type 3, A. Lateral or anterolateral dislocation of the radius with B. Ulnar fracture just distal to coracoid process. Type 4, A. Fracture of the radial head or neck with dislocation, and second component is fracture of proximal or mid third of ulna. Montagia equivalent fractures are: number 1, isolated radial head dislocation; number 2, fracture of proximal ulna with fractured radial neck; number 3, both bone proximal 1/3 fracture with radial fracture more proximal than ulnar fracture. Galeazzi fracture dislocation is fracture of the distal shaft of the radius with dislocation of the distal radio-ulnar joint. Gartland has classified supracondylar fractures of the humerus in children as flexion or extension fractures. Each types are subclassified as: type 1, undisplaced supracondylar fractures; type 2, angulated fractures with one intact cortex; type 3, completely displaced fractures; type 3 extension type is further classified as posteromedial and posterolateral. Bowman's angle or anteroposterior view of elbow is angle between the longitudinal axis of the humeral shaft and to that of physis of the lateral condyle. Normal Bowman's angle is approximately 70 degrees. Humerotrochlear angle on lateral x-rays of the elbow is angle between the longitudinal axis of the humerus and the axis of the condyles. Normal humerotrochlear angle is approximately 40 degrees. Milch classification of medial and lateral humeral condylar fractures. Type 1 is Salter Harris 4 stable fracture, and it will have fracture line through the trochlear groove. Fracture involves smaller outer margin of the humeral condyles. And type 2 Milch is Salter Harris type 2 epiphyseal unstable fracture, and it will have fracture through the trochlear sulcus, which involves the trochlear ridge, a bony prominence just lateral to the trochlear sulcus, which provides osseous stability to the joint. Neer and Horowitz classification for the humeral epiphyseal Salter Harris 1 and 2 fractures are: grade 1, less than 5 mm displacement; grade 2, displacement up to 1/3 width of the metaphysis; grade 3, displacement of the epiphysis up to 2/3 width of the metaphysis; grade 4, more than 2/3 displacement. Delbit classification of hip fractures in children is: type 1, trans-epiphyseal fracture; type 2, trans-cervical fracture; type 3, cervicotrochanteric or basal cervical fracture; and type 4 is intertrochanteric or pertrochanteric fractures. Tibial intercondylar eminence fracture, or else called tibial spine fracture, is classified by Mayers and McKeevers and is based on lateral X-ray of the knee. Type 1, minimally displaced. Type 2, 1/3 or 1/2 of the tibial eminence is elevated, which is hinged on its posterior insertion. Type 3, completely displaced tibial eminence fracture. Type 3 plus is displaced and rotated tibial eminence. Triplane ankle fracture in children is caused by external rotation force in a partially fused lower tibial physis. Triplane fracture can be 3-fragment triplane fracture, which is combination of Salter-Harris 2 and 3 fracture, or triplane fracture can be 2-fragment triplane fracture, which is Salter-Harris 4 injury. Epiphyseal fusion of the distal tibia in girls is at the age of 15, and in boys it is at 17 years of age. Fusion at the distal tibia begins from the center, progresses to medial and then to posterior. Anterolateral portion of the plate fuses last. Avulsion of the distal anterolateral tibial epiphysis plate is telofracture and is Salter-Harris 3 injury. Classification of fractures in adults. Clavicle fracture. Allman has classified clavicle fractures into group 1, which is middle third fracture, group 2 lateral third fracture, and group 3 medial third fracture. Neer has classified lateral clavicle fractures into type 1, where coracoclavicular ligament is intact, type 2, where coracoclavicular ligament is torn and displacement of the medial fragment, type 3, fractures involving acromioclavicular joint. Acromioclavicular joint injuries classification by Rockwood, simple way to remember is type 1, sprained joint, type 2, subluxed joint, type 3, superiorly dislocated joint, type 4, superior and posteriorly dislocated joint, type 5, severe superior dislocation, and type 6, inferior dislocation. Scapular fractures are classified according to the anatomical basis: fracture of the body, glenoid rim or fossa, fracture of anatomical neck, surgical neck, acromion, or fracture of coracoid process. Proximal humerus, Neer's classification: 2-part fracture, 3-part fracture, 4-part fracture, head splitting fracture, and impression fracture. The parts are: number 1, anatomical neck; 2, surgical neck; 3, greater tuberosity segment; 4, lesser tuberosity segment. Each part displacement should be more than 5 millimeters or angulated more than 45 degrees. Each type can also be associated with anterior or posterior dislocations. Cofield and Irving classification of shoulder dislocations: number 1, anterior; 2, posterior; 3, multidirectional. Each category is subdivided according to number 1, degree, which can be subluxation or dislocation; number 2, cause, which can be microtrauma, macrotrauma, or atraumatic; number 3, type, which can be acute, recurrent, voluntary, or involuntary; number 4, primary direction in multidirectional instability can be anterior inferior, posterior inferior, or all directions. Distal humerus fractures. Condylar fractures classified by Milch for either medial or lateral condylar fractures. Type 1, smaller outer margin, less than 30% of the articular surface is involved. This is a stable fracture. Type 2 will have larger fragment and involves more than 30% of the articular surface. This is an unstable fracture. Capitellum fractures. Type 1 is named as Hornsteinthal fracture. This is capitellar fracture which involves articular surface with large amount of subchondral and cancellous bone. Type 2 is Coca-Lorenz fracture. Here fracture involves articular slice of capitellum with little underlying bone. Type 3 fracture is crushed capitulum. Elbow dislocations. Dislocation of radius and ulna can be: number 1, posterior, which is either posteromedial or posterolateral; number 2, anterior; number 3, medial; number 4, lateral; or number 5, divergent dislocation with superior radioulnar joint disruption, which is either anteroposterior or mediolateral. Isolated dislocation of radius is either anterior or posterolateral. Isolated dislocation of ulna is either anterior or posterior. Monteggia fracture dislocation, Bado classification type 1 to type 4, has 2 components to each type, which has been described earlier. Radial head fractures classification by Mason. Grade 1, undisplaced segmental fracture. Grade 2, displaced segmental fracture. Grade 3, comminuted fracture. Grade 4, comminuted fracture associated with elbow dislocation. Scaphoid fractures classification is: type A are acute stable fractures, A1 tubercle fractures, A2 undisplaced waist fractures. Type B acute unstable fractures, B1 oblique distal third fracture, B2 displaced waist fractures, B3 proximal pole fracture, B4 fracture dislocation of the carpus, B5 comminuted fracture. Type C is delayed union of scaphoid, and type D is established non-union of scaphoid. D1 fibrous non-union, D2 sclerotic non-union or pseudarthrosis. Radial styloid fracture is also known as Schaffer's fracture, Hutchinson's fracture, or scaphoid impression fracture. Ulnar styloid fractures are often associated with TFCC injuries. Classification of thoracolumbar spine injuries, 4 main groups. Number 1, compression. Number 2, burst. Number 3, seat belt or chance. Number 4, fracture dislocation. Denise's division of spinal columns are: number 1, anterior column is anterior 2/3 of the vertebral body, including anterior longitudinal ligament with corresponding annulus fibrosus and nucleus pulposus. Number 2, middle column is posterior 1/3 of vertebral body, including posterior longitudinal ligament with the corresponding annulus fibrosus and nucleus pulposus. Number 3, posterior column ligaments are supraspinatus, interspinous, ligamentous flavum, and capsular ligaments. Bony components of posterior column are pedicles, facet joints, laminae, and spinous processes. Pelvic fracture classification by Tile 1988 is: type A, stable pelvic fractures, A1 fracture of pelvis not involving the ring, A2 minimally displaced fracture of the ring. Type B, rotationally unstable but vertically stable pelvic fractures, B1 open book fracture, B2 ipsilateral lateral compression fracture, B3 contralateral bucket handle lateral compression fracture. Type C, rotationally as well as vertically unstable pelvic fractures, C1 unilateral, C2 bilateral, C3 associated with acetabular fractures. Acetabular fracture classification is named after Lateral. Type A, partial articular 1 column fracture, A1 posterior wall fracture, A2 posterior column fracture, A3 anterior wall and or anterior column fracture. Type B, partial articular transverse oriented with portion of the roof attached to intact ilium, B1 transverse with posterior wall fracture, B2 T articular fracture, B3 anterior and posterior hemitransverse fracture. Type C, Complete articular both column fracture. This is floating acetabulum. C1, both column fracture with high variety. C2, both column fracture with low variety. C3, both column fracture and the anterior fracture enters the sacroiliac joint. Fracture and posterior dislocation of the hip. Thompson and Epstein 1973 classification. Type 1, dislocation with or without minor acetabular fracture. Type 2, dislocation with a large posterior fragment. This is unstable following reduction. Type 3, dislocation with severely comminuted posterior lip. Type 4, dislocation with fracture of the acetabular floor. Type 5 is dislocation with fracture of the femoral head. Pipkin has subclassified type 5 Thompson-Epstein classification into further 4 groups, that is femoral head fracture dislocation into 4 groups. Type 1, femoral head fracture caudal to the fovea capitis femoris. Type 2, femoral head fracture cephalic to the fovea capitis femoris. Type 3, type 1 or type 2 associated with fracture of the femoral neck. Type 4, type 1, type 2 or type 3 associated with acetabular fracture. Dilly has classified anterior dislocation of the hip into type 1 superior and type 2 inferior. Each of these are subclassified into A, no associated fracture, B, associated femoral head fracture, C, associated acetabular fracture. Intertrochanteric fractures by Boyd and Griffith is classified as type 1, fracture along the intertrochanteric line. Type 2, comminuted intertrochanteric fracture. Type 3, basically subtrochanteric fracture. Type 4, fracture of the trochanteric region and proximal shaft fracture in at least 2 planes. A.O. Muller classification of supracondylar fractures of the femur is as follows. Type A, extra-articular. A1, supracondylar not involving the joint. A2, 3-part with butterfly fragment. A3, comminuted supracondylar fracture. Type B, partial articular. B1, condylar fracture of the medial or lateral side. B2, condylar fracture extending into the intercondylar notch, medial or lateral. B3, shear fracture of posterior part of the condyle on lateral view. Type C, intra-articular fracture. C1, Y-shaped fracture. C2, Y-shaped fracture with extra-articular comminution. C3, Y-shaped fracture with comminution at the joint line. Tibial plateau fracture. Schatzker's modification, originally described by Hole and Moore, is as follows. Type 1, pure split fracture of lateral condyle. Type 2, split with depression of lateral condyle. Type 3, pure central depression of lateral condyle. Type 4, fractures of medial condyle. Type 5, bicondylar fractures, but the continuity of metaphysis and diaphysis is maintained. Type 6, dissociation of metaphysis and diaphysis in addition to bicondylar tibial plateau fracture. Ankle fractures. Log-Hanson's classification. First word of Log-Hanson's classification indicates the position of foot at the time of injury. Second word defines the direction of force applied to the foot. Each of these are further subclassified by the stages of severity from 1 to 4 according to the structures involved. Main groups of Log-Hanson's classification are: number 1, supination external rotation. Number 2, supination adduction rotation. Number 3, pronation external rotation. Number 4, pronation abduction. Number 5, pronation dorsiflexion. Weber AO classification of ankle fractures, number is 44 and types are type A, fracture fibula below the joint line, type B, fracture at the syndesmosis, type C, fracture proximal to the ankle joint. Talar neck fractures. Hawkins classification is type 1, talar neck fracture undisplaced, type 2, displaced fracture with subluxation or dislocation of the subtalar joint, ankle joint is normal, type 3, fracture with dislocation of body of the talus from both subtalar and ankle joints. Type 4 is fracture with complete dislocation of subtalar joint, ankle joint and talonavicular joint. Hawkins has classified fracture of lateral process of the talus. This is an intra-articular fracture due to forced dorsiflexion on inverted heel. Anteroposterior and lateral x-rays of the ankle in 15 degrees of internal rotation and in plantar flexion may be necessary. Tomograms or CT scans may be necessary to demarcate the fracture line. Type 1, minimal displacement involving talocalcaneal joint. Type 2, type 1 with talofibular joint involvement. Type 3 is comminuted fracture. Hawkins has also classified talar body fractures. Type 1, osteochondral fracture. Type 2, coronal, sagittal or horizontal plane fracture of talar body. Type 3, posterior process fracture. Type 4, lateral process fracture of body of the talus. Type 5 is crush fracture of the body of the talus. Type 1 Hawkins talar doom fracture is subclassified by Burnett and Harty as stage 1, a small area of compression of the subchondral bone. Stage 2, a small partly detached osteochondral fragment. Stage 3, a completely detached undisplaced osteochondral fragment. Stage 4, a displaced osteochondral fragment which is free in the joint. Calcaneal fractures. 25% of the calcaneal fractures are extra-articular fractures. Extra-articular fractures are posterior superior or posterior inferior tuberosity fractures, avulsion or compression anterior process fractures, sustentaculum talae fractures, and extra-articular body fractures. There are various classifications of intra-articular fractures of the calcaneus. 3 are mentioned here: Essex-Lopresti, Saunders, or Eastwood and Kenwright classification. Intra-articular calcaneal fractures. Number 1, Essex-Lopresti has described 2 patterns of secondary fractures, tongue type and joint depression type. Number 2, Eastwood and Kenwright in JBJS 1993 have described 3-part fractures. Type 1, the lateral wall is formed by the lateral joint fragment. Type 2, lateral wall is formed by the lateral joint fragment and talar body fragment. Type 3, where lateral wall is formed by apparently intact lateral wall of the body fragment on its own. Midfoot injuries can be: number 1, proximal articulation injuries involving navicular or cuboid, also known as Chopard joint injuries. Number 2, distal articulation injuries involving cuneiforms and cuboid, also known as Lisfranc joint injuries. Mid-tarsal dislocation or Chopard dislocation can be medial, lateral, or plantar dislocation. Hardcastle has classified Lisfranc fractures into type A, homolateral displacement; type B, homolateral incomplete displacement; type C is divergent displacement. Open fractures are classified by Costello and Anderson, described in 1976 and revised in 1984. Type 1 is a clean wound less than 1 centimeter in diameter. Type 2 has a wound more than 1 centimeter in diameter without any extensive soft tissue damage. Type 3 has 3 subtypes. 3A has extensive soft tissue damage or flaps but has maintained adequate soft tissue coverage of the bone. 3B has extensive soft tissue loss, periosteal stripping, and bone is exposed. Type C is an open fracture with arterial injury. Type 4 Gustello is those group of patients who will need reimplantation. Reported incidents of wound infection in Gustello are type 1 wounds 0 to 2%, type 2 2 to 7% wound infection, type 3A 7%, type 3B 10 to 50%, type 3C 25 to 50%, type 3C has 50% chance of having an amputation. Please refer the revision handbook for trauma scoring systems. Good luck to you.